Now that we've all eaten lunch, the challenge of staying awake becomes even more challenging. So we'll see how we do. I'm pretty sure I'm not going to fall asleep, but if I do, someone can wake me up. We're going to. So I mentioned before that currently available contrast agents in the United States really fall into two categories. There's the extracellular agents, which we just sort of talked about, and then there's Gadoxetate. And Gadoxetate is sometimes known as a biphasic agent. So it's extracellular initially, but then it gets taken up by liver cells and excreted by the liver into the biliary system. So it's both an extracellular agent and a hepatobiliary agent. So how do you make Gadoxetate? Well, if you start with this molecule, which is DTPA, chelated to gadolinium, you have gadopentate, also known as Magnevis, and that's the one that got officially approved by the FDA in 1988. If you then take gadolinium DTPA and you add an ethoxybenzyl group to it, then you no longer have Magnevis, you now have gadoxetate disodium, gadolinium EOB DTPA, and this is known commercially as Eovis in the United States, and it's known commercially as Primavist in the rest of the world. The FDA would not allow Bayer, the manufacturer, to call it Primavist in the United States. I'm thinking it might be because primo sounds a little bit like premium, and so maybe anyway, for whatever reason, it was not approved as Primavist. That's why it's known as Eovis in the United States. Now, this EOB is very interesting because this EOB is what converts Magnevis, which is an extracellular agent, into Eovis, which is a biphasic agent that's extracellular initially, but then gets taken up by liver cells and excreted into the bile ducts. The EOB is also what allows this agent to bind somewhat weakly to proteins, and we now know that the binding to proteins increases its relaxivity. So Gadoxetate gives you more bang for the buck. And that's both a good thing and, in a way, a bad thing, as I'll mention in a few moments. Okay, so we start with the liver. And the liver is composed of cords of hepatocytes. And these hepatocytes have canaliculi in between them and transporter proteins that communicate with the canaliculi. The hepatocytes, the space immediately outside of the hepatocytes is known as the space of Desai, or the perisinusoidal space. And then there's this sort of fenestrated layer of sinusoids, and that separates the perisinusoidal space from the sinusoid, or the sinusoidal space. So when we first give gadolinium EOB DTPA, just like any extracellular agent, it will distribute in the extracellular space, meaning the sinusoids and the perisinusoidal space, like that. And if this was just gadolinium DTPA, it would stay in the extracellular space. So some of it would be in the perisinusoidal space, some would be in the sinusoid. But this has ethoxybenzyl, and this ethoxybenzyl gets recognized by transporting polypeptides on the sinusoidal surface of hepatocytes. And so this is actually cellular and molecular imaging in the year 2017, because this transporter recognizes this chemical group, and this molecule with gadolinium gets into the liver cells. And over time, it then gets excreted. Some of it gets excreted by multi-drug resistance associated proteins into the bile. Some of it gets excreted by other multi-drug resistance proteins back into the sinusoid. So some gets excreted into the bile, some gets excreted back into the sinusoid, but over time, more and more accumulate within the liver cell. And so the liver concentration of the Eovis, or of the Gadoxetate, gets higher and higher. And notice then that as the concentration within the liver cells gets higher and higher, notice what happens to the concentration in the extracellular space. It gets cleared from the extracellular space. And so now if we do a thought experiment and ask ourselves, what will the liver look like 20 minutes after giving this agent, you might imagine that the liver will look bright because the agent is inside the liver cells. You might imagine that the bile ducts will look bright because the agent's in the bile ducts. And you might imagine that the blood vessels will look dark because the agent has been cleared from the blood. And that's exactly what we will see. Now, something else to take into account is I mentioned that EOB binds to proteins, and the binding to the protein gives it more bang for the buck. So now ask yourself, how much protein is there in the extracellular space, and how much protein is there inside the liver cells? And if you said, I bet there's more protein inside the liver cells than there is in the blood, you'd be exactly right. And remember that the more protein binding there is, the more bang for the buck there is. So then you might think, aha, I bet 20 minutes after giving this agent, if the liver is functioning well, the liver is going to be very bright because all of the EOB gadolinium is going to be in the liver cells, and with all that protein binding, I'm going to get all this bang for the buck, and the liver will be very, very bright. And that's exactly what we'll see, so we'll show that in just a moment. So here is gadolinium DTPA, and gadolinium DTPA gets excreted by the kidneys. And here is ethoxybenzyl. So here is gadolinium DTPA ethoxybenzyl, and this is going to get excreted by the kidneys. It's going to get excreted by the bile ducts because of the ethoxybenzyl. It will bind to proteins because of the protein binding, and that gives us high relaxivity. And it turns out that this chelate holds onto gadolinium pretty tightly. And so there's not a lot of dissociation. So this is a fairly safe agent to give. Let's now talk a little bit more about the excretion of this agent and the uptake by the liver and excretion. So it gets taken up by organic anion transporting polypeptides. That's a horrible mouthful. So for the rest of the lecture, I'm going to call it OATP. So when I say OATP, it's organic anion transporting polypeptides. That's what takes it into the liver cells. And what spits it out of the liver cells into the bile duct is the multi-drug resistance associated protein 2. And so these transporting mechanisms are what is related to hepatic uptake and hepatic excretion. Now, lesions in the liver that have OATP receptors will look bright. So guess what lesions that don't have OATP receptors will look like? See, radiology is not so hard. Lesions without OATP receptors will look dark. So now all we need to do is remember what lesions do and what lesions do not take up OATP. So this is an emerging model. Some of this has not been proven scientifically for everything, but this is our working model. So lesions that have little or I should say one thing. OATP is expressed by liver cells and in general, not by anything else. So if there's something in the liver that's not of hepatocellular origin, like a cyst, a hemangioma, a metastasis, or a cholangiocarcinoma, it will have low or no OATP expression. If it's a tissue that's not made of hepatocytes, it will have low or no OATP expression. Scars, fibrosis, blood vessels. It turns out that most hepatocellular adenomas, even though they're made of hepatocytes, those hepatocytes decided that they don't want to bother having OATP expression. So most hepatocellular adenomas, over 90%, have low or no OATP expression. Most hepatocellular carcinomas have low or no OATP expression, and some dysplastic nodules have low or no OATP expression. And we'd expect all of these things to look dark or very dark after giving Gadoxetate in the hepatobiliary phase. These things have preserved OATP expression. Most FNHs, regenerative nodules, most perfusion alterations, the underlying parenchyma will usually take up OATP, and about 5% of cancers. So these will look dark. These will look iso to bright, and these will look dark. So let's see what that looks like in the hepatobiliary phase. Here is a liver. The underlying liver is normal, hence the liver looks very bright, and hence the blood vessels look very dark. Here you see a little bit of the biliary excretion. And here you see a focal nodular hyperplasia that looks bright. And the focal nodular hyperplasia looks bright because its cells have preserved OATP expression. You'll see that the scar looks dark. Why does the scar look dark? Because the scar is made of fibrous tissue, not hepatocytes. So the scar will look dark. Now here's a cirrhotic liver. And notice that the cirrhotic liver looks not quite as bright as the normal liver. It looks more heterogeneous because we see all of these fibrous bands, all these little dark lines or scars. The scars don't take up the gadoxetate because they're not made of hepatocytes. Here's a hepatocellular carcinoma. It looks dark because 95% of HCCs have reduced OATP expression. And here's the bile duct looking bright. Now, livers that are cirrhotic sometimes don't work so well. And so here's an example of a functioning liver. And here's an example of a liver that's not functioning so well. So if the cirrhotic liver is functioning well, then the gadoxetate will be very good at detecting lesions. If the liver is not functioning so well, then the gadoxetate is not so good at detecting lesions. So in patients who don't have good uptake of gadoxetate, then the hepatobiliary phase is not particularly helpful. So how can you tell when you have good hepatobiliary phase uptake? Now you might guess that it's based on the bile duct. You might guess, I see biliary excretion here, I see biliary excretion here, hence these both must be adequate quality. And if you were to guess that the answer, you'd be incorrect. The reason is that in cirrhosis, you may have diminished OATP expression, but you also have elevated MRP2 expression. So evolution has made it in such a way, the liver has been evolved in such a way that when it starts to get sick, it ramps up the ability to excrete toxins. So MRP2 expression goes up. So whatever gadoxetate gets into these liver cells, it promptly gets excreted. So do not use the biliary system as your clue to whether the image quality is adequate. Instead, look at the contrast between the blood vessel and the liver. If the liver is functioning adequately, it will pull enough gadoxetate out of the extracellular space so that blood vessels become clearly dark relative to the liver. If the blood vessels are not clearly dark relative to the liver, then the hepatobiliary phase is impaired, and you should make a note that it's impaired. And if you don't see a lesion, then you can't be that confident about the absence of the lesion. Now, if I see a lesion in a situation like this where the liver is not functioning well, then I can interpret that as being there's a lesion there. But if I don't see a lesion, I'm not sure that whether there's a lesion or not. So don't look at the bile ducts, look at the liver to blood vessel contrast ratio. Now earlier I mentioned that with an extracellular agent we have the early arterial, late arterial, portal venous, and delayed phase, and the graphs look somewhat like this. Let's get rid of all the noise and let's focus now on the tumor in green and the liver in orange. But instead of giving an extracellular agent, what happens if I give gadolinium DTPA EOB? Remember, the EOB is going to accumulate in the liver cells. So instead of the liver de-enhancing, the liver will progressively enhance and get brighter and brighter and brighter. Notice how much brighter the liver is with gadolinium DTPA EOB than it is with an extracellular agent. And notice why this might be valuable for imaging tumors. Because in this hepatobiliary phase, when the liver is very, very, very bright, let me get back to the transitional, well, okay, let's talk about it now. Okay, we'll get to this in just a second. So we have this hepatobiliary phase in which the liver is very, very bright. So at this point, contrast, the enhancement of the liver is mediated by gadoxetate that's inside the liver cells, by intracellular gadoxetate. During these early dynamic phases, Enhancement is mediated by extracellular gadoxetate. So at this point, the agent is mainly extracellular. At this point, the agent is mainly intracellular. So somewhere between here and here, it must have transitioned from being extracellular to intracellular. And we call that transitional period the transitional phase. So when we give gadolinium DTPA EOB, we have an arterial phase, we have a portal venous phase, we do not have a traditional delayed phase, instead we have a transitional phase, and then we have the hepatobiliary phase. This hepatobiliary phase, wide imaging window, potentially several hours long, but typically we like to image at about 20 minutes. Now, after the contrast agent gets into the liver, it starts to get excreted, and typically at about 5 or 10 minutes, we'll see enhancement of the bile ducts as shown over here. And ultimately, the bile ducts will be even brighter than the liver. Now, why is this hepatobiliary phase helpful? Well, notice that if the liver is functioning well and the liver is bright, and the tumor is reading the textbook and doesn't have OATP expression, look how much darker the tumor is than the liver. Very high lesion to liver contrast. In addition, although this is off-label use of the product, notice you could use the product off-label to image bile ducts because the bile ducts become bright. Okay, so now let's look at an extracellular agent on the top and gadoxetate in the bottom row. Pre, 30 seconds, 40 seconds, portal venous phase, 3 minutes, 5 minutes, 20 minutes. Do the images look similar here at 30 seconds? Yes, they do. Do the images look similar here at 40 seconds? Yes, they do. Do the images look similar here in the portal venous phase? Starting to look a little different, subtle differences. The liver's starting to look a little bit brighter here, but pretty subtle. But by the time we get to 3 minutes, now there's clearly a difference, isn't there? Notice how the blood vessels are brighter than the liver because the liver's starting to de-enhance. Meanwhile, the contrast agent remains in the blood vessels because the contrast agent is being cleared only by the kidneys. Here, the contrast agent is being cleared by both the kidneys and the liver is getting quite bright. And so the blood vessels are becoming iso-intense to liver. Notice in some places we can't even see the blood vessels anymore. And then by 20 minutes, the blood vessels are black. We have excretion into the bile duct, and the liver is much brighter, say, than adjacent organs like the kidney, as opposed to here, where the liver is darker than the blood vessels and the liver is darker than the kidney. So these are the differences between an extracellular agent and gadoxetate. And this period over here, where the contrast agent is transitioning from extracellular to intracellular, is called the transitional phase. Okay, so that's a little bit about gadoxetate. What's it really good at? Well, it's really good at some things. It's really good at detecting metastases in the normal liver. It's really good at differentiating focal nodular hyperplasia from hepatocellular adenoma. It's good at bile leaks in biliary anatomy. This is off-label. I won't talk about it further today. What about in the cirrhotic liver? If the liver is functioning, it's very good at detecting early HCC, HCC precursor lesions, and quote-unquote hypovascular HCC. It's also good at differentiating vascular pseudo lesions versus true lesions, and it's also good at differentiating low-grade dysplastic nodules from high-grade dysplastic nodules or early HCC. So this is what it's good at, these things. And that means it's bad at everything else. So gadoxetate is really good at these things, but not good at other things. Meaning, if you have a normal liver and someone does an ultrasound, and the ultrasound suggests hemangioma, but the recommendation is to do an MRI to confirm hemangioma, should you give gadoxetate? Well, let's see, is gadoxetate good at hemangiomas? I don't see it here, so don't do gadoxetate MRI. What about the history is, patient has a normal liver, they have colon cancer, PET CT showed one lesion in the right lobe of the liver, the surgeon now wants to do a hepatectomy. But before they do a hepatectomy, they want to do an MRI just to make sure there's no metastases elsewhere in the liver. Would you want to do Gadoxetate? Gadoxetate, really good at detecting liver mets. I think I do want to do Gadoxetate. We'll go back over this later, okay? But this page is very important. This is what Gadoxetate is good at, and you can infer that if it's not on this page, Gadoxetate is not that good at it. Let's review some of this. All right, here's a patient. This is, I think, 2009, one of the first cases we did. And patient had a CT scan. And does everyone see the metastasis? It's pretty subtle, but it was actually detected. It was hot on PET. So the metastasis is right here in segment 4A/B. It's right there. There's a metastasis. But before they did a resection to remove that metastasis, they did an EOVIST MRI, Gadoxetate, arterial phase, portal venous phase, transitional phase. Does anyone see the metastasis seen on CT? It's right here. Does anyone see any other metastases? Well, this is the transitional phase. Let's go to the hepatobiliary phase. Do you see any of the metastases? Let's magnify the images. So here's the metastasis on CT. Pretty subtle. That's that same metastasis on MRI. But we see other metastases, don't we? Some are in the caudate. Some are in segment 2, and there's this one here, segment 8. Now, is the detection of this metastasis important? The answer is yes, because this is what the surgeon was planning on doing. But after this Gadoxetate MRI, the surgeon changed his resection line to that. So in this case, it didn't cancel the surgery, but it changed the surgical plan from a lobectomy to a trisegmentectomy. Yes?
You're saying that Gadoxetate acts as like a blood pool or an extracellular agent in the early phases, right? So why is it necessarily bad for detecting hemangiomas?
I think we'll get to that later, but the main reason is that it's not so much that it's bad at detecting hemangiomas, it's just that one of the ways that we characterize hemangiomas is we like for them to follow the blood pool. So when you give an extracellular agent, the blood pool stays bright, right? So it's bright on the arterial phase, bright in the portal venous phase, bright in the delayed phase. So if we see a lesion that holds on to contrast, we say, okay, that's a hemangioma. Now, hemangiomas still follow the blood pool when you give Gadoxetate, but now the blood pool goes dark. And so then it just becomes more confusing because now you see a lesion that was bright in the arterial phase, iso-intense in the transitional phase, and dark on the hepatobiliary phase. Is it impossible to make the diagnosis of hemangioma with Gadoxetate? No, it's not impossible. Would you be able to make the diagnosis? Yes, because you're really smart, but it's just harder. So why tie one hand behind your back? If you know the indication is hemangioma, don't give Gadoxetate. Now, obviously, sometimes you don't know, and sometimes you might do an MRI for other purposes, and there's going to be an incidental hemangioma, but it just makes it a little bit harder. Okay, now, here's a 58-year-old woman, breast cancer, and she has an elevated alkaline phosphatase. Elevated alkaline phosphatase in someone who has a possibility of having liver metastases makes you worried that there's liver metastases. This CT was read as negative. Does anyone see the metastasis? Rhetorical question. You might argue, well, maybe over here, I don't know. Read as negative. So they called me and Cynthia Santillan, and we said, well, why don't you consider a Gadoxetate MRI? Every one of these dark dots is a metastasis. This patient does not have cirrhosis. What this patient has instead, on this one image, and I counted them, this patient has 833 metastases on this one slice. The liver was riddled with metastases. So there is no imaging technique that is as sensitive to tiny metastases as Gadoxetate. So if the history is rule out metastases and the underlying liver is normal, Gadoxetate is a very powerful imaging agent. Does that mean that you should use Gadoxetate for every single person in whom liver metastases may be suspected? No, not necessarily. It depends on how important it is to know whether they have metastases and how many they have. So for example, depending on the situation, if someone's going to be treated with chemotherapy, in this case we want to give the Gadoxetate because we didn't know that they had metastases. But let's say we knew this patient had 5 metastases that we could see on CT, and we could follow them, then if the patient's not going to be considered for surgery, they're just being treated with chemotherapy, then is it really necessary to see all the Mets? Probably not. So use your judgment, but if it's important to see each individual metastasis, then consider Gadoxetate. Here's another important indication, FNH versus hepatocellular adenoma. We have 2 women here. One is, they're both about 30 years old, and they both have arterial phase hyperenhancing nodules, masses, in segment 6/7 of the liver. So which one is the FNH and which one is the hepatocellular adenoma? Well, I don't know, but let's give Gadoxetate and see if we can figure it out. Well, when we give Gadoxetate, notice that this lesion fades to isointensity and then reaccumulates the contrast and has a dark central scar because the central scar is made of fibrocytes, not out of hepatocytes. So this is a focal nodular hyperplasia. This thing that kind of looks like a focal nodular hyperplasia in the arterial phase does not hold on to Gadoxetate. This is a hepatocellular adenoma. This patient we followed. This patient ended up getting a hepatic resection. Now, some people have noticed that some hepatocellular adenomas do take up some Gadoxetate, and they're not as black as this one, and that can cause confusion. One thing you can look at is you can look at the internal architecture. You see how the FNH has a lobulated morphology, central scar, and then this sort of radiating pattern of septal bands radiating from the center. So this architecture, in addition to the uptake, is very characteristic of FNH. This is also taking up the Gadoxetate, but in more of a patchy pattern, right? This does not have the same architecture as this, with this central scar and radiating network of fibrous septa. So when you see lesions that take up the agent, also look at the architecture. If you see this architecture, it's FNH. If you see this architecture, think adenoma. Gadoxetate in patients with normal liver function and cirrhosis are very good at detecting quote-unquote hypovascular HCC. And this person is 68 years old. She has a 25 millimeter cancer in the liver. Does anyone see it? Reasonably good quality MRI with an extracellular agent. I didn't see it, but I think all of us can see it now, right? So there it is, a lesion that has diminished OATP expression, looking dark relative to the liver, and invisible essentially up here. And so this was biopsied, and this is a path-proven HCC. Gadoxetate is very good at detecting precursor lesions. So some of you may not know this pathway of hepatocarcinogenesis, so let me briefly review it. In hepatocarcinogenesis, we start with benign, cirrhotic, or regenerative nodules. A cell within here becomes dysplastic, and that cell replicates, and those cells replicate, and eventually within this nodule we have a new nodule that forms, and this new nodule is more dysplastic than the cirrhotic nodule, and this is known as a low-grade dysplastic nodule. And then within the low-grade dysplastic nodule, a cell will develop that has some mutation or epigenetic alteration that has some survival advantage, and it will form a clone of cells that gradually outstrip their neighbors and grow and grow and grow, and eventually we have a new nodule that's a high-grade dysplastic nodule. And then within the high-grade dysplastic nodule, we'll have a cell that's an early cancerous cell, and eventually through clonal expansion, it will form an early HCC or carcinoma in situ. And then there's some cell in here that will develop more mutations or epigenetic alterations, become frankly malignant, and through clonal expansion, eventually form a small, frankly malignant or progressed HCC, and then over time this will grow. At any rate, during this hepatocarcinogenesis, this is what happens to the arterial blood supply. Notice that the arterial blood supply actually diminishes just a little bit before going up. So if you're trying to detect HCC based on arterial flow, really you can detect them when they're large and progressed, meaning frankly malignant. Sometimes you can detect them when they're small and progressed, but you can't pick up carcinoma in situ using extracellular agents as a general rule. What about OATP expression? Notice that OATP expression starts to decline usually in the transition from low-grade to high-grade dysplastic nodule, so that OATP can be used to pick up high-grade dysplastic nodules and carcinoma in situs that would be essentially invisible based on their arterial blood flow. Now, in the United States, how important is it to detect high-grade dysplastic nodules in early HCCs? I'll be honest, I'm not so sure it's so important in the United States with the way we practice. But in Japan and Korea, it's very important to detect these nodules because the surgeons are very aggressive at resecting them. So to some extent, depending on where you practice, detecting these precursor lesions can be very, very important. At any rate, here's an illustration of that phenomenon. Does anyone see a 14 millimeter nodule? So this is a $2,500 MRI. And we did a pre-contrast, early arterial, or late arterial, portal venous, in phase, out of phase, T2, diffusion. Anyone see the 14 millimeter nodule in this $2,500 MRI? Well, I don't, but we also did a hepatobiliary phase. And now I think, especially now that we have the arrow pointing at it, I think we can see the 14 millimeter nodule. Notice that this nodule is visible only in the hepatobiliary phase. So this hepatobiliary phase only hypointense nodule in the European and the Asian literature has a differential diagnosis of early HCC, high grade, and occasionally low grade dysplastic nodule. So these are known as high risk nodules, and we typically consider a 6-month follow-up. And so that's what we did. We recommended a 6-month follow-up. The patient came back 9 months later, and 9 months later this nodule was now hyper-enhancing and washing out, and now measured 22 millimeters. So it had gone from a high-risk nodule to meeting imaging criteria for HCC. So again, in the United States, we tend to follow these things. In parts of Asia, they might actually resect this. And so detecting those things is very important. Now here's something that even in the United States is very important. So it's the differentiation of a pseudo lesion from a true lesion. So here's a true lesion. That's a hepatocellular carcinoma. And here's a true lesion. This is a hepatocellular carcinoma. But what about that little thing in green? What about that little thing in red? Now, which one is a cancer and which one is not? Now, given the color coding, some of you might be able to guess, but had these not been color coded, would you have been able to guess? Well, let's go to the hepatobiliary phase. So we go to the hepatobiliary phase over here. Does anyone see a corresponding lesion? And the answer is no. So therefore, that's a pseudo lesion. What about over here? Does anyone see a corresponding lesion over here? And I think the answer is yes. Right there, there's a corresponding lesion. So that is not a pseudo lesion, that is an HCC. And so that potentially makes a difference, because if you are going to be a surgeon and you want to resect, you'd have to resect this as well as this. Now, none of us are surgeons, right? But some of us are interested in interventional radiology. And so those of us who want to do interventional would either want to treat this while you're treating this, or at least be aware of this. So even if you decide not to treat it, at least be aware of it and follow it closely. Okay, so what is Gadoxetate not so good at? In the normal liver, no limitations for detection. But in the normal liver, not so good at hemangioma, and not so good at differentiating metastases from primary liver tumors. In the cirrhotic liver, terrible for infiltrative HCC, not so good for tumor in vein, not good for decompensated cirrhosis, not good at differentiating HCC from cholangiocarcinoma. So I think Srinath asked about hemangioma. So here is an example of a hemangioma with an extracellular agent, and here is a hemangioma now, same person, same patient with Gadoxetate. And you can see that one of the things we rely on with hemangiomas is the fact that they follow the blood pool and look brighter than liver on the delayed images. With Gadoxetate, they still follow the blood pool, but the blood pool tends to get darker, and so they look darker than liver on delayed images, which can be a little bit confusing. And I know that some of you are saying, well, okay, this case, come on, Claude. I mean, I could get that. Okay, smarty pants. So how about this one? So how many of you might have called this a cholangiocarcinoma? This patient has cirrhosis. And I already told you that cholangiocarcinomas like to have rim enhancement in their arterial phase. So how many of you would have called this a cholangiocarcinoma? It even seems to have a little bit of diffusion restriction. So I bet a lot of you, well maybe or some of you, might have called this a cholangiocarcinoma. But this is not a cholangiocarcinoma. This is a hemangioma. And you need to know that in cirrhosis, hemangiomas can become sclerosed. And when they become sclerosed, they shrink down. And the puddles of enhancement coalesce together, so they look like they have arterial phase rim enhancement. And the clue is that in the portal venous phase, this is still sort of holding on to contrast. And notice that it kind of filled in from outside to in. And also notice how sharply defined it is on the T2 single shot. Now, I'm not saying that any one of us should look at this case and say, hemangioma, slam dunk, next case. The point of this case is, in fact, that just the opposite is to say that hemangiomas can be a little bit difficult when you give Gadoxetate. This would have been a slam dunk with an extracellular agent. It becomes a little bit of a head scratcher when you give Gadoxetate. And so with an extracellular agent, it would have been a no-brainer. And we might have recommended a biopsy on this, and that might not have been the end of the world, but why do an unnecessary biopsy? Anyway, this was a hemangioma. Now, I got this case correct, but we all have our humility, don't we? So, or we all are shown our humility, or shown that we should be humble. So here's one of my more embarrassing cases. So here's a 45-year-old woman, and she has a long, long history of birth control pills. She's been on birth control pills since she was 7 years old. No, okay, I'm exaggerating, but 25-year history of birth control pills. And she has this lesion, hyper-enhancing. And look, it's dark in the hepatobiliary phase. So, what would a 45-year-old woman who's been on birth control pills for a long, 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 long time have with low OATP expression? Slam dunk, hepatocellular adenoma. She wanted to get pregnant. Surgeon was worried that this might bleed based on its location, so they did a hepatectomy. Guess what this ended up being? If anyone gets this, I'll give you $1,000 right now. Okay, so what this ended up being is a piece of spinach. So 2 years earlier, she had ruptured appendicitis. And it's a known phenomenon that, it's very rare, but just like, what is it, Fitzhugh-Curtis, I think it was? Is it Fitzhugh-Curtis where you get the pain around the liver from appendicitis? So the inflammation so perforated appendicitis, you can sometimes have deposition along the liver of ingested matter. Now, I don't really know this was a piece of spinach. It was a piece of vegetable matter. So that's actually what the pathology report said. It was debris with cellulose walls. This is vegetable matter. And so I ended up recommending a hepatectomy for a woman who had a piece of spinach lodged against her liver that had elicited a foreign body reaction. Now, the point of this case is not, there's another little story. So we submitted this as a case report because I thought pretty cool or interesting that, we got fooled by a piece of vegetable matter against the spinach, and they rejected it. And the comment from the referee was, any good radiologist would have known that this was not a hepatic lesion. And so I couldn't really respond to that, because they had just basically said I'm not a good radiologist, and so I didn't really know what to do. So we never published it. Would anyone have gotten this right, by the way? Maybe none of us were any good. Okay, none of us are good. We all suck. Okay, at any rate, the teaching point of this is not that next time you look at this, you should say piece of spinach. The point of this is that hypointensity in the hepatobiliary phase is very non-specific. So very sensitive, but very non-specific, and that's a pitfall of using hepatobiliary phase agents. Infiltrative HCC can be very difficult to find. So this is a hepatobiliary phase image with Gadoxetate, does anyone see the infiltrate of HCC? Now, the clue to the fact that something is desperately wrong here is that the blood vessels are brighter than the liver. So that tells you there's something wrong here because the liver should be brighter than the blood vessels. So something is wrong. Either this liver is not functioning or this liver is diffusely replaced by cancer. But boy, who would have called infiltrate of HCC on this? Oops. Hold on, I gotta undo here. Okay, so here is the arterial phase and all these splotches of enhancement, that's all infiltrative cancer. So this person had a very large infiltrative cancer that's essentially invisible in the hepatobiliary phase. Diagnosing HCC can be a little bit difficult with Gadoxetate. So here is an extracellular agent, and here is Gadoxetate. Do these lesions look very similar in the arterial phase? Yes, they do. They look very similar. So can we tell whether they're a cancer? Well, let's look at more delayed images. On the more delayed images, notice that this washes out and has a capsule. This washes out, but does anyone see the capsule? You can't see the capsule. And in order to call this an HCC, this is so small, you need to see washout and capsule. So why can we not see the capsule here? It's probably because the liver is enhancing so much that the enhancement of the liver is obscuring the enhancement of the capsule. So just be aware that when you give Gadoxetate, it may be hard, it's easy to detect the HCC, but it may be hard to prove with 100% certainty that it's an HCC. So this is a LIRADS-5, and that's a LIRADS-4. Now there's other limitations of Gadoxetate, arterial phase artifacts. There's the occasional HCC that expresses OATP, and there's a few other artifacts. I'm not sure I'm going to show all of them. So here's the list of all the artifacts, of all the limitations. We'll go through a few of them. Okay, so patients simply cannot hold their breath as long in the arterial phase when you give Gadoxetate. So here's an extracellular agent. Here's Gadoxetate. These images were acquired 2 days apart. Portal venous phase, 3 minutes. Good quality image, good quality image, good quality image. This is a good breath holder. But what happens in the arterial phase? In the arterial phase, patients with Gadoxetate sometimes just simply cannot hold their breath as long. And we think that Gadoxetate basically reduces everyone's comfortable breath hold capacity by maybe 10 or 15 seconds. So if you can hold your breath for a minute and you take Gadoxetate, you're only able to hold your breath for about 45 seconds. Does that matter clinically if you're doing an MRI? Of course not, because we never do 45-second breath holds. But what if you can hold your breath for 25 seconds and I give you Gadoxetate and then you can only hold your breath for 10 seconds and your sequence is 15 seconds long? Then you're going to have motion artifacts. Now, don't quote me on the first part of that, on the 10 to 15 second reduction. We haven't proven that. But over and over and over again, we've seen that about 20% of patients who have good arterial phase with extracellular agents cannot hold their breath, at least during the imaging time as well, when we give Gadoxetate. We don't understand the mechanism. Now here's a patient who got Gadoxetate, and look at the liver. On the hepatobiliary phase image, the liver is much darker than the portal vein. So what's happening? Is this liver not functioning, or is this liver so iron overloaded? Notice how bright the liver looks on this R2 star map. Is the liver so iron overloaded that the signal loss from the iron overload overwhelms the enhancement of the Gadoxetate? And that's what's happening. So in other words, if the liver is very iron overloaded, extremely iron overloaded, then the signal loss from the iron overload overwhelms the enhancement of the Gadoxetate, and it will look like you used an extracellular agent, except for the fact that you'll see biliary excretion. So in severe iron overload, do not give Gadoxetate unless you're interested in looking at the bile ducts. But if you're interested in looking at the liver, do not give Gadoxetate in patients with extreme iron overload. Patients with decompensated cirrhosis. well-compensated cirrhosis, poorly compensated cirrhosis. I showed you this image at the beginning. Well-compensated, poorly compensated. Don't look at the bile ducts. Look at the blood vessels. If the blood vessels are much darker than the liver, then you have good quality images. If the blood vessels are not, this is an inadequate hepatobiliary phase. Some HCCs don't read the textbooks and express OATP. HCCs that do take up OATP will look bright in the hepatobiliary phase. So remember, until now, every HCC I've shown you has been dark in the hepatobiliary phase. So that introduces a conundrum, because benign lesions like focal nodular hyperplasias can also look bright in the hepatobiliary phase. So how do you tell the difference between a benign FNH and a malignant HCC? Sometimes not so easy. So what you look for is the following. The HCC should look like a smear of brightness. The FNH should have a scar and radiating fibrous septa. The HCC may or may not have a capsule. The capsule will manifest as this hepatobiliary phase hypointensity. Why is the capsule hypointense? Because the capsule is made of fibroblasts and collagen, not made of hepatocytes, so it doesn't have OATP, whereas the FNH will not have a capsule. Now sometimes you can't tell the difference, but if you see something with a central scar, FNH, if you see something with no central scar, and you do see a capsule-like appearance, that's an HCC. Okay, let's summarize what agent to use. So after all that, this is probably the only important slide I'm going to show. But if I had started with this, you all would have walked out, and then I would have nothing to say. So, do you want to give Gadoxetate, or do you want to give an extracellular agent if you're imaging the liver? By the way, if you're not imaging the liver, don't give Gadoxetate, use extracellular agents. But if you're imaging the liver, which one do you pick? Okay, so if there are relative contraindications to Gadoxetate, don't give Gadoxetate, give an extracellular agent. For example, total bilirubin greater than 3.5. Or, regardless of the bilirubin, you did a previous study and the hepatobiliary phase was suboptimal, meaning the liver was not much brighter than the portal vein. In those cases, give an extracellular agent. Similarly, if the patient could not hold his or her breath at all in their arterial phase, don't give Gadoxetate, give an extracellular agent. And if the patient has severe iron overload, don't give Gadoxetate, give an extracellular agent. The exceptions would be if the purpose of the exam is to look for bile leaks or biliary anatomy. In that case, the fact that they can't hold their breath in their arterial phase doesn't really matter. In that case, the fact that the liver is not that bright doesn't really matter. So you could still give Gadoxetate for biliary leaks, but if that's not the indication and the patient couldn't hold their breath last time or has severe iron overload, give an extracellular agent. Okay, so that's if there's relative contraindications. What if there are no contraindications? Either the images were good quality last time or you've never done it before, bilirubin's low. What do you do? Well, let's start with the patient with no cirrhosis. So then you give Gadoxetate in 1, 2, 3, 4, 5 circumstances. If you suspect FNH, if the patient has cancer and you want to do pre-hepatectomy staging, if there's high suspicion of occult metastases that have not been detected by imaging, for example, the alkaline phosphatase is elevated. If you want to look for a bile leak or biloma, and this would be a really niche utilization, if you're trying to look at biliary anatomy in living donor candidates, you give Gadoxetate. In every other indication, do not give Gadoxetate to an extracellular agent. Hemangioma, routine metastatic surveillance, vessel patency, arterial anatomy, cholangiocarcinoma, characterization of all liver lesions with the exception of FNH. Do not give Gadoxetate, give an extracellular agent. That's if the patient doesn't have cirrhosis. What if the patient does have cirrhosis? Okay, if they've had prior local regional therapy, use an extracellular agent because the arterial phase is the critical phase. And we know that a treated lesion won't take up EOVIS in the hepatobiliary phase. So it doesn't help us to give Eovist. So don't give Eovist if there's prior local regional therapy. What if there's no local regional therapy and the suspicion is infiltrative HCC or vascular invasion? Don't give Eovist. I just already showed you how bad Eovist is at detecting infiltrative cancer. What if you want to diagnose a nodule that was detected on a previous scan and you really want to see the washout and the capsule? Well, don't give Eovist because Eovist won't show you the capsule as well as I showed you in that example, so give an extracellular agent. What if you see a lesion? I did not show you an example of this, but what if you see a lesion and the whole and you suspect it's a cancer, but you don't know if it's an HCC or a cholangiocarcinoma? Or you see a lesion and you're not sure if it's an HCC or a hemangioma, kind of like that strange hemangioma case I showed you. Then give an extracellular agent. So when do you give Eovist? You give it when you're trying to differentiate a vascular pseudo-lesion from a true lesion, and we do this all the time at UCSD. We do it for surveillance. When you're trying to detect small early HCCs and their precursors, then Eovist can be very, very helpful. Okay, and that was it on gadolinium contrast agents. Another break.